Hi, it's been quite a while since we've gotten together to do one of these updates, but I am here again today with Bonny Specker, epidemiologist, who is going to give us a COVID-19 update and let us know what has been happening in our region, across the state, in our country, and in the world. And she's also going to talk about the BA.5 variant and also some things like risk for infections and more. So Bonny, what's been going on with COVID?
Thanks, Chelsea. As you mentioned, we'll talk about the BA.5 variant and also just some historical things. And as you also mentioned, the risk from reinfection. So there's a lot to talk about since it has been a while, so I'll get going here. I just wanted to kind of do a flashback on when this all started. This was from something I did for the city back in April of 2020. And it was talking about how COVID was looking like the influenza of 1918. And this was one of the slides I showed. And I talked about how when I taught epidemiology, we would always go over this outbreak. And people, the students in the class, were always amazed how no one really remembers it, or like how it just was sort of lost from memory, even though 675,000 people died in 1918 from this outbreak. And we would often talk about, like, how could that be? Well, we now have over 1 million deaths in the United States. And I think that it just seems odd, because I have a hard time, like, how did people not know that? But you can see how you sort of like stop thinking about the numbers, because it gets to a point where it's just so overwhelming. And I think that's happened now, and a lot of people do believe that this is over, and they're done with it. They don't want any more COVID, but I don't think the virus is done with us. And people have sort of forgotten, or aren't, like, don't listen anymore. But right now there's over 350 Americans dying every day from this virus, and we just sort of have blocked anything that relates to COVID from our minds. And I think it's a numbing sort of a way to deal with it, is just ignore it. So, try not to ignore it too much. I mean, I think we do need to get back to somewhat of a normal life, but hopefully some of the information will help that I'm giving today. As far as the BA.5 variant, in the weekly updates, this is one I posted that went through June 11th, and you can see the BA.5 just starting out. This is the one I had in yesterday's handout, and you can see that it has increased very rapidly. If you think of drawing a line, this way across the BA.2 and then the BA.5, you can see it's a much steeper line. So it's spreading much more quickly than the previous versions of this virus. In the United States, as of the data that were out yesterday, it represented 78% of the COVID cases. In our region, which is Colorado, North and South Dakota, Utah, Wyoming, in that region of the United States, we're at 80% of the COVID cases are this BA.5. So it's definitely here. And there's a great blog that this Eric Topol, he's at the Scripps Research Institute, pretty brilliant person. He does a blog and he talks about how the virus is becoming more fit, especially this BA.5, but how each variant of COVID has had an advantage, and it outcompetes with the previous one. That's why it takes over. And you have this increased growth advantage, or increased fitness, we call it, immune escape, and there's stronger immunity wall built. So the virus protects itself better from the body's immune system so that it can spread. So the Omicron is evolving to be more fit, and this BA.5 is the most infectious variant that we've had to date. It's evading prior immunity, so it looks like reinfection rates are high. Although that data is not tracked nationally, there are some local regions that track it. For example, where this Eric Topol's from San Diego, California, they actually track reinfection rates, and they're finding that it's much higher with the BA.5 variant. The other thing that's a little bit concerning with these variants is that with BA.5, there's now only one effective treatment, whereas with previous versions, there were multiple treatments that were effective against the virus, but this Paxlovid is really the only effective treatment for the BA.5 variant. And this is probably one of the most disturbing data that are recently been put out there. The references to this are below, and this Eric Topol summarized the data. But if you look, this is both a measure of relative risk, and this is a measurement of absolute risk, this column. And these green dots and lines represent a person who's only been infected once. So this is their risk of hospitalization if this is their first infection. If they get infected a second time, during that second reinfection, the risk of hospitalization increases. So the severity of reinfections is greater with each reinfection. These are people that were infected 3 or more times. They have a much higher risk of being hospitalized than someone that's only been infected as the first time. And you can see that it's relevant for pretty much all of the organs. Like here's pulmonary. Your adverse effects from a pulmonary infection or from COVID affecting the lungs is high. You know, that's one of the highest risks with a first infection, but it's even much higher with the third infection. So I think this is kind of important data because it's saying that every time you get infected, this virus causes more damage than it did in the previous infection. So you really want to minimize this reinfection rate. Now, switching over to the different ways we're measuring the level of COVID in the community. And I think this is really confusing to a lot of people. It's really confusing to me. I have no idea why the CDC did this, although I have a few kind of personal ideas. But there's two things. There's this community level. This is with the new one that they came up with. And it's based on the rate of new cases in the previous week, as well as the rate of new hospitalizations. And I think they came up with this because the rate of new cases is very difficult to determine, as we'll talk about in just a second, because of all the home testing that's done. So you can't have an indicator based on just new cases. So they're like, well, let's look at hospitalization data. So the rate of new hospitalizations are taken into account with this community level, as well as what percent of the hospital beds are COVID occupied. So that's how they come up with low, medium, and high, is a combination of these three things. And the problem is hospitalization lags behind infection. So you see community levels that are high if they had high infections a week or two earlier. So it's not a real good way of surveillance or knowing what's going on at this current moment. It's more what went on last week. Now, community transmission, this is what they've used all along, and it's the rate of new cases, just like with community level, but it also looks at test positivity. And that's where this home testing is also causing problems. So you have this rate of new cases. So it's impossible to determine that accurately since home testing data is not included in those new cases. So if I test myself today at home and I'm positive, I'm not going to be counted as a new case. I will only be counted as a new case if I go to the clinic after my positive test and say, I want a treatment for this. I want Paxlovid, or then the clinic will test me again. That will get reported and I'll be able to get treated. But because of that, the test positivity is high. The people that are going to the clinics are people that are likely to have tested at home and are going to get treatments. So it's causing test positivity to be high, and the reporting of new cases is low because of that at-home test kits, if that makes sense. One of the things that the CDC is very interested in, and the government in general, is how do we do surveillance for this virus if we have all this at-home testing? Well, one way is to actually measure the virus in wastewater, in sewage. And you can kind of see what's going on in a community by looking at the levels of that virus in wastewater. If the community's having a high infection rate, the virus in wastewater is going to be high. So that's almost a way of knowing what's going on right now in your community, is through this wastewater viral load. And that is being done down in Vermilion. Dr. Victor Huber, you did a video with him once before. He's actually monitoring it there, and he did just receive a grant to do it in several other locations. So hopefully we can work it out that Brookings can do surveillance through sewage. Not the job you want.
It would be really awesome if that was available.
Yeah, it's an important one, but not one I would want to do. I'll stick to the computer. As far as mortality in South Dakota, it has been updated through March of 2022. That's this dot right here. And this blue line is what happened in 2020. This is 2021. And then here we have 2022. So you can see these other lines are all previous years from 2010 through 2019. You can see that the deaths are higher in the fall in both 2020 and 2021. And they were high this year in January and February. And March, we're pretty much back down to where we were prior to COVID. And that fits with the numbers. I mean, it's been very low since March as far as case numbers. And it's only been recently that they've started to go back up again. If you look at the total deaths, this is the average number between 2010 and 2019 per year. And if I subtract that from what we actually observed in these years, these are the number of excess deaths. And then this is the number of COVID deaths per mortality data. So the excess deaths are higher than what's been reported in terms of COVID deaths. But we've talked about that before, that it could be that people weren't going to the hospital or the clinic when they should have because they didn't want to get out. Or it could be that a lot of these excess deaths are actually COVID deaths that were not identified as COVID related. So it could be a variety of things. And someday people will look back over, the actual death certificates and try to figure that out better. I'm starting with the US data. I know we normally have that at the end, but I just thought since we were talking about variants, it would be nice to see what the timing of the different variants for COVID. And here we have Omicron, and we've got the original one, and now we've got these other BA4 and BA5 variants. So this is what's happening nationally. And if you look at deaths, This is where we're at over the 300 per day. We have 2,500 deaths last week in the United States. It's low, but it's not going any lower, which is sort of disturbing. It's almost like a high baseline number of deaths from COVID each week. Now, I thought it would be nice to look at these two sort of on top of each other, because what you see is that the number of deaths don't really follow the number of cases. And that's because we've gotten very good at treating it, and that this Omicron is not as, probably doesn't have as high a case fatality rate as some of these earlier ones. So here, these peaks, this one wasn't a very big peak, but it had a lot of deaths. Same with here, because they didn't know how to treat it. It was also a virus that went much, the effects were much deeper in the lung, whereas now it's more up in the upper respiratory. But, people said, well, Omicron's not a problem because it's not that severe of a disease as the original virus was. But it was so infective and so many people got infected that it did lead to a peak, a pretty good peak in the number of deaths that happened. And that's just because there were so many people that got sick. We now have this increase going on, whether that causes an increase down here, whether this plateaus and is done with earlier is yet to be seen. If you look at the world, this is the number of cases. Again, this is the BA5. That's what's going on internationally. And the number of deaths are starting to come back up as well. Now, if you look at Brookings, we were quite low here in March and April, and we've been holding sort of steady the last month or so at about 30 to 40, 30 to 50 cases per week. And if you look at the age distribution, it's a lot of the older people, and I'll show you some of the vaccination data. This is a group that has a high vaccination rate of receiving at least one vaccine. But the vaccine effectiveness declines significantly with time. And we have a very low percent of people that have been boosted. So this could be a reflection of those older people getting vaccinated a long time ago and have not yet received a booster. If you look at the hospitalization for Brookings, it's bouncing around between 1 and 3 and 0 actually per week. This past week, there were 3 hospitalizations, and about 5% of the hospital beds in the Sioux Empire region, which includes Sioux Falls and Brookings, is about 5%. All 3 of these cases actually are at Brookings Health System. And we haven't had that many deaths, which is good. That's a good sign. If you look at South Dakota, it's going up. It flattened out this last week, and it'll be interesting to see if this starts coming down or if it's just, doing this where next week it will go up into a higher rate. But it is low here again, just like in Brookings. Now, if you look at the percent of South Dakotans who have ever tested positive, and this is kind of this is done very simply. It's just the number of people that have tested positive divided by the population size. So some of these could be reinfections. The South Dakota Department of Health doesn't separate out reinfections. So this could include reinfections. If you look at South Dakota versus Brookings, South Dakota's here in the yellow, Brookings is in the blue. Brookings County has lower infection rates or people that have ever tested positive than the rest of the state. And the way you interpret this is if you look at this age group, 24% of the South Dakotans age 60 to 69 have tested positive compared to 17% in Brookings County. Overall, 28% of South Dakota is tested positive and 24% of the people in Brookings County. Now, if you look at hospitalization statewide, this is following the case data pretty good. It's increasing. And again, the majority of these are in the older people. And if you look at the hospitalization rates by age, you see that 8.4% of the people 60 to 69 who are diagnosed with COVID end up being hospitalized. And that increases to 24% in the 80 plus, or 1 out of 4 people in that age group. But down at the younger ages, it's much lower. But that's not saying that they aren't hospitalized. Here, this is deaths, and they've stayed low. So even with this increase in BA5, we haven't yet seen an increase in the number of deaths. And the deaths we are seeing tend to be in older individuals. And if you look at case fatality rate, this is the percent of people who are diagnosed with COVID in the particular age group that die. And for instance, here in the 60 to 69, 1.8% of the people who are diagnosed with COVID actually died. The yellow is South Dakota data, and the blue is data I calculated from the Minnesota Department of Health back in 2020. So it's kind of a different virus, right? At that point, back then it was more the Delta. And these are the mortality rates that Minnesota was seeing then. So the difference here, like how we have a much lower rate, that wasn't true when we were back in the Delta phase. We were pretty close to Minnesota, but we're looking better now, 2 years out. So this is confounded with the problem of the different variants. Looking at this, I should probably go back and recalculate Minnesota, but I haven't had a chance to do that. One thing to note, I didn't include any of the deaths in the less than 20. There have been 5 deaths, pediatric deaths in South Dakota, and all of these were posted since September of last year. So, and that's probably a reflection of the high number of cases among the pediatric age group. If you look at the population that is vaccinated by age, what you see, the yellow is statewide, the blue is Brookings. Brookings has a higher vaccination rate. This is one vaccine only, so we don't know if they completed it or not. Brookings has done much better statewide, except in this 18 to 24 year age group. And if you look at boosted by county, so I don't have this broken down by age. The age breakdown is data I have to request from Department of Health each week. So they only provide the data by age for those that received at least one vaccine. But if you look at boosted, 26% of Brookings County residents have received a booster. That is extremely low. And 49% are considered fully vaccinated. They've received either the one Janssen vaccine or both Moderna or Pfizer. That also is not very good. So the vaccination rates for Brookings, for people that probably still have some protection, is probably quite low, because those that only got one vaccine way back when they first came out, there's probably little benefit to that right now because it's been so long. So it's something that has to be sort of boosted, right? So this gets to this whole Swiss cheese thing that we've talked about before. None of these different interventions or preventions are perfect. And you really need to use a wide variety of efforts, preventive efforts, to keep yourself or your family safe and other people safe. And I think it's important to realize that many of these different interventions are ones that you can personally choose to do, and other ones are shared. For instance, the whole idea with vaccines falling under shared responsibility, you know, I might not need a vaccine, but me getting a vaccine will help protect someone who can't get a vaccine, or it will decrease the spread of the virus throughout the community by that herd immunity effect that we've talked about before. But we have the physically distancing. You know, I'm out there. I have not been wearing a mask unless I'm around a lot of people in a closed area, enclosed area. And if I am around a lot of people and I might not have a mask, I try not to stay there very long. And I try to meet with more people if it's outside. You know, it's just there's certain things that you can do in everyday life to help prevent the spread of this virus, as well as from you getting infected from it. Now, I've added some websites here. There is our free test kits. I think the Fed government is on their third or fourth set of ones. You just go to this, it's super easy. The US Postal Service is the one that does this, and you get them pretty quickly. We also have the CDC data tracker and the Department of Health COVID dashboard websites. And then Eric Topol, he has great updates and great discussions of this. Some of it is he does a lot of virology, so a lot of it's biological data, but I think he also has some other good general data. That weekly data update that is posted on the city website, I actually put that out in a blog each week on Wednesday, and the blog's website's there, and you can sign up and get subscribed to it, and then it will automatically let you know if something's posted. So I do put updates on that blog if people are interested in that. So that's all for this month.
Well, thank you, Bonnie. I know it's been a while, but it's great to have the updates. And like anyone that is viewing here, you know, make sure you visit these websites to continue to keep updated. Yes, I think there is that mentality, you know, that we just don't want to think about it anymore, right? We're sick of it. Everybody's sick of COVID. But it is still around, and we do still have to do what we can to help keep ourselves healthy and help keep others healthy as well. So I appreciate it, Bonnie. Until next time.
Thanks. Take care, Chelsea.